it's so nice to be with you all this morning. Thanks for tuning into this little session. I'll be speaking on a systematic review we've been doing as a team on Hansen's disease, also known as leprosy in the US. This was undertaken by myself. I'm at LSU New Orleans as a fourth-year medical student. No disclosures to make. Also, alongside a great statistician, PhD candidate, Will Eaton, who's at Tulane School of Public Health and Tropical Medicine in New Orleans as well. And our wonderful mentor, Dr. Yotsu, who is both based out of the School of Public Health and Tropical Medicine at Tulane, as well as in Japan and the WHO. None of my co-authors or team members have any disclosures either. So just to jump right in, a bit of background, Hansen's disease, also known as leprosy, is a chronic infectious disease from the Mycobacterium species of leprae mainly, and a little sometimes from lepromatosis as well. Those cases are arising. Yeah, as was mentioned, Hansen's disease, also known as leprosy, is a chronic infectious disease from the Mycobacterium species, mainly leprae, although lepromatosis has been rising, transmitted via respiratory droplets after prolonged contact. That means, usually weeks contacts, months of contact with an infected person, but it has also known to be zoonotically transferred from infected nine-banded armadillos. They're really common in some parts of the US, as well as other small mammals like red chipmunks, squirrels, and others. The incubation period is usually 5 to 10 years, but it can be longer. It primarily affects the skin, so it is a neglected cutaneous disease. And it causes hyposensate, hypopigmented, dyspigmented lesions. But it can also affect the extremities, leading to a lot of disabilities. It can cause people amputations, the peripheral nerves, including their autonomic nervous system, the mucous membranes, and often, if it progresses deeply enough, it can go to the internal organs, including the kidneys and testes. So despite it becoming less globally prevalent over time, some people think of it as an old world disease. It really does remain still a major cause of debilitating disabilities and psychosocial impact, especially because the stigma around it still remains. And even though we have had some developments in medications, we haven't had that many over the last 100 years. The Ridley Joplin classification system was established in 1966 to categorize it into 5 different groups based on clinical and histological characteristics. Those are tuberculoid, borderline, permomatous, after mid-borderline, and then of course lepromatous leprosy. In 1982, WHO was like, we probably want to introduce a simplified system to help guide treatments. They came up with paucibacillary and multibacillary. Paucibacillary is up to 5 skin lesions, equivalent to tuberculoid or borderline tuberculoid. And multibacillary is going to be more than 5 lesions, more severe, and it spans the other types with a higher acid-facet bacillus count in the skin smears as well. The classification systems really were to help guide treatment and patient monitoring and make it easier for people out in the community who are helping to diagnose and treat. There's a multi-drug treatment regimen that was introduced with dapsone, rifampicin, and clofazimine. The duration is meant to be for 6 months for paucibacillary and 12 months for multibacillary. And this is just showing how that range goes from tuberculoid all the way to lepromatous, from stable to unstable, back to stable. So for this, we looked into 4 databases systematically, Medline via PubMed, Web of Science, Embase, and Scopus. And these were all full-length studies published in English until June 2nd, 2023, using the help of Covenants. It identified duplicates, but we actually handpicked and went through all 5 additional duplicates. We had to look for papers from the 1800s and early 1900s, which were very difficult to find in some cases, but we did. 7,059 studies were identified, and then 5,475 unique abstracts were screened by myself and other independent reviewer. Any disagreements were handled by our PI independently. 403 publications from 1896 to 2023 met our inclusion criteria, and then 168 were included after excluding for reasons related to the wrong study setting, if it wasn't diagnosed in the US or based on a US case, a wrong outcome, and a wrong study design. If it wasn't a case report or case series, we did do a parallel look into the surveillance reports, but that was part of a different study. So, our publications covered a time span from January of 1798, actually all the way through June 2023. There were 111, so over 80% of publications, importantly, from the case series and case reports that are from after 1980, after WHO really introduced their scheme. Sample sizes ranged from 1 to 46, and there were 328 unique cases identified from this group. The median age was 43, but it ranged from 3.5 all the way to 87. The majority were male, and the majority were white. We did have to do work to systematize classification of race and ethnicity, since sometimes there were outdated terms, even derogatory terms. Some of these papers So we had to go through and really standardize this for the US Census format. We did have 4% of native Hawaiian or other Pacific Islanders, which we thought were interesting. So this is just a geographic distribution of the cases based on the state of clinical presentation. This is something we built out after careful evaluation. As you can see, Louisiana has had the most over time. That's not surprising since the National Leprosarium and the Hansen's disease program is based here in Carville. And so a lot of people were based everywhere, but this is where they would clinically present. And that's an important distinction. Although we did see a correlation based on where people were living and where they clinically presented for treatment. Other states in the Southeast are especially, have a lot of case counts that were reported in the literature, but there are many states in the contiguous US who haven't, and so there could be underreporting going on. So this is just another diagram we built, and a Sankey diagram, which shows the case dispersal patterns across the US. Most cases were more in North America, specifically in the US. We thought it was interesting that other cases that came outside of North America, a lot of them came from East Asia, especially Southeast Asia and the Pacific, but they widely dispersed across the continental US, which can be seen. Most cases in the US have been based in Louisiana, but other focal concentrations are in California, New York, Florida, Iowa, and Arkansas. And we see those dispersal patterns remaining somewhat consistent over time, although increasing in recent years. So this is just a graph showing our transmission mode over time that we captured by decades. Most publications did not actually report this information, unfortunately. But the studies that did, most cases were transmitted by that community contact. And the majority of cases, interestingly, published in the 1950s were contracted while in military service abroad. It's unknown exactly how, but it's kind of interesting. There are a growing number of the zoonotic cases from armadillos, especially in the southeastern US, in recent years, for the last 50 years, really. So these are just, an interesting look at the diagnostic modalities, how those have been changed over time. Most cases over time consistently have been reported based on pathology from biopsy, which is not surprising, reliable, sensitive, specific method. But PCR has started to take off in the 2000s. It really was starting to be utilized for diagnostics, including leprosy in 1990. The diagnostic modality was not unfortunately discussed in a lot of the published cases, though. So this is looking back at the WHO classifications. Majority of reported ones where they were reported were multivacillary, which is important because more severe disease forms that require a longer duration of treatment have been increasing over recent years in the US. And this is just showing how that overlays with really Joplin, the more old classic classification scheme. The majority of those that were reported were lepromatosis, so that matches up with multivacillary. These were with polymorphic lesions that are difficult to treat. And it also shows, it's interesting that papers even more recently published were reporting on this system as opposed to WHO classification. So, 1/3 of all cases presented to the National Hansen Disease Program in the US, in Louisiana, which is great. The state of residence, state of diagnosis trends do match up. And most people were in states, where they have those National Hansen Disease Program resources. That is something positive. Prior to 1960, most cases were associated with military service abroad. But since 1980, there's been a growing proportion likely transmitted through armadillo contact and other zoonotic transfer. Skin biopsy has remained the diagnostic modality, but PCR is becoming more utilizable. It's still out of reach for places that don't have, the utility for it. It's costly. So based on really Joplin, most cases in this review were lepromatosis, and based on WHO, it kind of follows that, majority where they were reported. This is again not a majority when you think about how many did not report were multivacillary. Multi-drug regimens with rifampicin, dapsone, and clofazimine have dominated the protocol since 1980, which is not surprising. But other antibiotics have been increasing, including the use of macrolides such as clarithromycin, minocycline, and other tetracyclines, as well as even fluoroquinolones. We still have a long way to go in terms of thinking about new drug regimens and also eradication procedures that could use these as well prophylactically. Studies reporting on Hansen's disease in the US are still very limited. Even when we look at our surveillance report studies, there's just not that many that are comprehensive. Our analysis showcases there are potentially emerging trends with increased zoonotic transfer in the US, specifically in the southern US. Limitations included a lack of complete information across many of the metrics we're looking at. Case counts do not really fully capture the scope of cases that have been reported by the surveillance centers over time to the WHO, although our data align well with that. And further research is needed to clarify between, the burden of Hansen's disease and the changing geographic and demographic distributions to see who's most at risk and who should we be thinking about in the future to really put resources towards. Standardized reporting methods for diagnostic and treatment are still needed if we're going to study this properly in the US. These are just some references that went into this, and thank you so much for tuning in.